Hello everyone, welcome to Neuraxis 2020. Here we are starting day 2 scientific session, and here we go. And welcome to all faculty today. And with this, the first lecture today, we are privileged to have Professor Manish Arora sir, is a very eminent and honored faculty in field of physiotherapy. He will be talking about neuromuscular troubles caused by Atlas misalignment. Dr. Manish sir, welcome sir, and thanks for joining us. It's over to you. You can share your screen and present, sir. Thank you.
Thank you, sir. First of all, I'd like to thank all the organizers and the people behind this wonderful event, which is being organized by the NeuroAccess group. And I think this is the 6th NeuroAccess which is being organized. And I congratulate the organizers, especially Dr. Shagun Agarwal, Dr. Dharam, and Dr. Harpreet, for making this wonderful effort, especially in the time of COVID, to reach to one and everybody across this nation. To add a little drop to that wonderful knowledge that you all are going to get through this event, I'm going to present a short, brief introduction how Atlas will be a real troublemaker in the life of the patients that you see. There's one little vertebra, but one very important vertebra, which can cause loads and loads of problems. Just a little thing, I was trying to keep myself updated, trying to learn things. That's my journey going on. Already Dr. Dharam sir has given my introduction, but that's just a customary part of my slides that I have. Apart from learning, I'm trying to communicate my own thought process with the world. I've got about 150 papers published and presented in various conferences. This is at WCPT, that's World Congress of Physiotherapy Singapore. That was something which we patented and which we rationalized to be our concepts called myokinetics. So coming to the domain which we are going to be today in, Atlas and its faults. The cervical spine, we knew as physiotherapists, especially 30 years back when I was learning physiotherapy, we were more concerned about the lower cervical spine, which could give you radicular pains and spondylitic changes. No doubt, we are still focused on that, but then there's something much more beyond than that. That is the upper cervical spine, which is responsible from headaches to busier symptoms, which I'm going to discuss in the next few slides. This is a normal alignment of atlas to axis. And you can see the green line, which is drawn to the center of the atlas. Of course, there are definable points to which we mark on an X-ray. But this green line is absolutely parallel to the yellow line on the axis. So the alignment of atlas to axis is said to be perfect. But if you could see the image which just hopped in, there could be some misalignments occurring in the atlas. One, it could be an anterior superior atlas. When the anterior part of the atlas now goes superior, which is evident from the blue line, which is no longer parallel to the red line. Intentionally in this slide, I've taken the occiput, which is also not perturbed. Sometimes people believe it is the shifting of the occiput. Here, only the atlas has misaligned in reference to axis. And this is opposite to that. From anterior superior, it has gone to anterior inferior. That is inferior on the anterior side. Then this is what you will see in an X-ray image, which we call as APOM, anterior posterior open mouth image. There's a perfect alignment, but then there could be a tilting of the atlas either on the right side or on the left side. There could be a lateral atlas malposition where the atlas literally goes to the right or left. But the biggest challenge or the biggest problems that we get in atlas is its rotation. It can rotate on its axis like this. And this rotation, of course, we can see through X-ray, which will be a little beyond this little talk which I'm having because I've got 20 minutes only, and it will take at least a couple of hours to explain you all the things, how to do that, which we can do sometime later. But then we can find this rotation through an X-ray. And these all problems clubbed together can create a lot of problem. And as I said, especially the rotation of atlas. Now, what brings these problems? It could be trauma, like you have a fall or you get jerks, or it could be these particularly lovely things that you adopt while you are glued to your computers or you're short of spaces. So all these things can bring faults in your atlas alignment. 90% of these problems in today's world are brought by postural misalignments, or in other words, the soft tissues that are controlling the atlas. One little example I have taken in this, but we are not limited to just this. There are many other soft tissues also which bring the similar kind of faults in the atlas. But as I said, 90% of these problems in today's world are postural and are brought by imbalance in the soft tissues that control the movement of these joints. Like this. This is rectus capitis superior, inferior oblique. And you could see how, if one side becomes tight or the other side becomes tight, it can change the alignment or position of the atlas vertebra. And this rotation fault, if you could see in this little animation, is pressing upon something marked with red, yellow, and blue. What are those things? There are arteries and veins, and of course, the yellow nerve is the biggest concern of all. And this is the powerhouse nerve of your body, the vagus. Functions of vagus are much more than what I have listed here. It could be a stimulation of production of gastric juice, it helps in digestion, appetite, sweating, regulating mood, cardiac rhythm, your respiratory rate can be affected by it, and all put together can affect your parasympathetic clouding. It can definitely take away your parasympathetic tone and put you in trouble. And along with other things which we are going to see in the next few slides, atlas misalignment can lead to nausea, heartburns, vertigo. I get a lot of patients who have this vertigo and we just treated by fixing the atlas. And there's a huge success that we get. Redness of face, tachycardia. I'll show you some research work where we have decreased the resting heart rate in many individuals. Rigidity of neck, cervical pain, headache, Meniere's syndrome, difficulty in swallowing, excessive sweating, insomnia, sense of throat, lump, cold hands and feet, irregular accelerated heart rate, constipation, chronic constipation, unjustified diarrhea, thyroid problems, unilateral numbness or tingling in the scalp, and so on. TMJ, hyoid, axis, and atlas is a very important correlation. Why I said correlation? Because they work together and they do regulate the postural tone of our entire body. If you just keep your hands behind your occiput and below the occiput, if I could be seen, and close your eyes and move your eyes side to side, you'll feel even with the movement of your eyes, you could feel some changes behind your occiput at the suboccipital area or at the atlas area. So the controlling center of the posture and tone are here. And this is what can happen if there's a misalignment in your TMJ atlas complex. The entire body can start deviating from its normal path. From forwarded posture, you have abnormalities in your spine, and going down the lower limb will be seen in this animation. Let's be more picturized here to make you understand that better. If you see the right side of the image first, you can see on the right side how the tone on one side of the body is getting affected. You get many patients who say, I get a pain and dysfunction or weakness in the one side of the body. Think about that. Not only there, but then think about the atlas when your atlas can press upon the brain stem and cause other effects like this. So everything, one way or the other, atlas could be blamed, but you have to find whether it is so or not, because certain similar symptoms can come from other things also. Cervicogenic headaches. The trigeminal nerve nuclei and the C1, C2, 3 nuclei go together and go to the same area of the brain. And that is why sometimes when you have an atlas or an axis problem, you get a headache, which is very similar what you'll get with the trigeminal compression. This is very similar that you get pain in your shoulder when your heart is involved because there's the same neurological reference zone. And then this, again, we have a little research work to be shown to you later. It can control your eyes, ears, your glands, because the sympathetic chain lies very closely to this, and an atlas malposition can affect the sympathetic chain, which can affect your eyes. In fact, I had some visual problem, and today you can see, till after 4 years, I had started developing the visual problems and without my glasses. And there are no contact classes as well. It's all because I worked on this chain and made myself better. But before we start talking about what we can do, beware. It is not as simple as it looks in these slides. This could be dangerous if without testing, you just start manipulating the atlas, because you have to find the fault and then correct it. And also, you have to be cautious that similar symptoms can come when atlas is not malpositioned or not hypomobile, rather it is hypermobile or susceptible to hypermobility. Because if you, with the similar symptoms, especially if the atlas is subluxated, as you can see, it could be rheumatoid arthritis, there are many other reasons as well. If it is subluxated and you do try to manipulate or try to move the atlas, it can even cause paralysis or death. Don't worry, you can screen it and do that. But these are the same symptoms you could get with atlas instability. You could see balance problems, blurred visions, dizziness, migraine headaches, fullness in the ears, fatigue, headaches, tinnitus. All these things, vertigo, can be seen when there's a C1, C2 instability. Because the ligaments that should stop from the atlas from going towards the spinal cord are moving, get damaged. It could be most commonly the transverse ligament, the tectorial membrane of the alar ligaments. So we have tests where we can find out and prevent this kind of Bezier effect. You see, normally when a stable joint is there, nothing happens to the vertebral artery, but then these rotations in an unstable atlas can cause brain stroke and damage. So tests like Sharper's test, lateral shear test, which would be Googled and found, you can find out how to test and make yourself safe. So once we have found those problems, whether it is instability or it is hypermobility, we have various methods by which we can correct the fault. And once we correct, we will be able to treat all the different kinds of problems which were listed. We can also use X-rays, I showed you some images, or we can do by physical examinations. As one simple test, which if you can see my image on the screen, this thing is just flex your neck as much as you can, and then without not allowing the flexion to go away, try to take the neck to one side of rotation or to the other side of rotation. If your rotation is limited to one side, it could be because of atlas malposition. Now, if your atlas is right rotated, if your atlas is rotated to the right, it is posterior on the right side, it will not like to go to the left side. So if you have a left side rotation, that means your atlas is right rotated posteriorly. So in a patient, you can make him supine, bend his neck fully to a point, then you feel a movement. If you keep a finger between the atlas and your occiput, and you feel a movement between them and flexion, then you do the rotation, and you see the right side is rotated. That means right side is less rotated. That means there's a left problem. If left side is less rotated, that means a right side problem. So once you have found out, you can use various mobilization techniques. In the same position, you can maintain a pressure on the atlas from posteriorly and do the same mobilization of rotation. Or you could use snags, which we have been using very successfully. We have been using the Mulligan method only for treatment. Though assessment, we rely on our more of our osteopathic and chiropractic techniques, which give us a very precise element of finding the fault. Or you could go for manipulations or soft tissue releases. There's a very limited time, but then we very successfully can release different muscles separately, like we can release the rectus capitis inferior oblique separately from the rectus capitis posterior major, and we can balance the soft tissues. Or if you are really a technological freak like me, there are two very important things which can make your job very easy. One of them is a drop table. I'm showing you the image and how on the drop table we fix the atlas and give a quick thrust to correct the fault. Or we have this kind of adjusters which are now available, and I think more than 2,000 to 3,000 physios are using these adjusters these days to correct the fault. So this is the research component I was talking about. We have published this research where we use snags. As I said, we've been using Mulligan more in our practice because I have these MPD students who are not that conversant with the manipulations, but we tested using chiropractic techniques, and then we corrected the atlas malposition, and we could reduce the resting heart rate in old people by about 4 heartbeats in everybody. That means as the age advances, the parasympathetic effect goes down, we were able to get it better. We have already communicated where we have changed the blood pressure in individuals using a manipulation of the atlas. And this is another article which is published already, where we have treated the hearing abilities in people, again senile people and young people also, with correcting the atlas faults. So there could be a huge opening for you to treat many different kinds of people who have not been treating people with eye dysfunction, ear dysfunction, heart rate, gastric problems, gastric reflex, which you could treat by atlas. And of course, you can treat musculoskeletal problems. So sticking to the time as ordered by the organizers, I just want to say magic is not temporarily instant here, but staying healthy in long term. So we have to change the methods by which we have been treating to make the health more and more long lasting and better. Same like Corona, the things which have come will go away. We have to stay healthy and make people healthy. Thank you very much. I would ask Shagun sir to take over for any questions.
Thank you, Manish sir. It's always pleasure to listen with you.
Thank you, sir. It's an honor.
Sir, thank you for enlightening us with such an important topic. There is no question at all, but I would appreciate, sir, you have bring up a new techniques and new technology in the physiotherapy field, because I know you from last more than 26 years now, and I could privilege means you have bring up a lot of techniques in the physiotherapy field, and whatever it is that either drop table is there, or the adjusters are there, or the new manual therapy techniques are there for the pain management. It's always you which brings up new. So thank you, sir, for enlightening us, and I would like please guide us in the future also. Thank you. Thanks a lot, sir,
Thank you,
for
sir. It's a
giving
pleasure.
us time.
Thank you.
Thank you. Thank you, sir.
Thank you, Manish sir, and for such a wonderful lecture. And now
It's an honor.
we are moving with another next session and we have with us Dr. Karthik Babu. He is Associate Professor, Manipal College of Health Professions, Mahe. And he'll be talking about trunk after stroke. So we welcome Dr. Karthik. You can proceed with your lecture.
Sure. Very good morning to one and all. Yeah, myself Karthik. Thanks for the introduction and thanks for the invite. Am I audible to
Yes, sir.
everyone?
Yes, sir. You have to give command to
Yes,
computer
yes.
for changing the slide, sir.
Sure, sure,
Right, sir.
sure. So I have shared my PowerPoint with an organizer.
Yes, you have to give the computer to change the slide. You just say next slide, it will be changed.
Sir, I have shared my PPT with organizer. You
Yes, sir.
just run through
Dr.
the
Karthik,
PowerPoint.
you have to just say next slide. Then you would find out your next
Yeah,
slide.
yeah, yes, sure, sure. Yeah, sorry, sir. Yes, yes. Please, next slide. We'll go ahead. Next one. Next slide. Please. So in this talk, I will just give you an overview about neurophysiological biomechanical connections of trunk, assessment and treatment of trunk. Next slide, please. As we all know that the pyramidal system involvement result spasticity in extremities. What we do not much concern about is the involvement of extrapyramidal system. So basically the rubrospinal tract, reticulospinal tract, and vestibulospinal tract. So these are the extrapyramidal tracts that are responsible for maintaining the postural tone, particularly to maintain the trunk alignment. So the reticulospinal tract is directly controlled by a cerebral cortex, whereas the vestibulospinal tract maintain the tone indirectly through receiving a lot of sensory inputs from the body. What happens after stroke is that the people they lack mobility. So because of inactivity and disuse, the sensory input would not reach to the cortex. So the cortex would not direct the extrapyramidal system to modulate the tone. So after stroke, so we find two type of a tonal abnormality. The first is spasticity in extremities. The next one is the hypotonicity in the trunk musculatures. Please, next slide. So we learned from biomechanics that we have two systems in our body: the tonic muscular system and phasic muscular system. The tonic muscular system should provide a postural tone for the phasic muscular system to work. This is applicable to torso as well. So in trunk, we have transverse abdominals and oblique abdominals. They are the tonic musculatures that should provide a postural background so that the phasic muscular system can work selectively. So one can do a selective upper torso or lower torso movement, depends on what kind of the task the person do in a daily activity. The next slide, please. So since these deep-seated trunk muscles, the postural muscles, are small unit, the fast twitch the fibers, and the reaction time is faster. So which is conditional for any arm-initiated trunk or extremity movements. So this we say a postural set. Before we move an extremity, these muscles should maintain a tone to provide an optimal postural background or optimal postural alignment for extremities to move. Next slide, please. Next slide, please. Right. So now another interesting fact is that unlike the extremities, majority of the trunk muscles are attached to facial connections. They are attached to linea alba. So involvement of one side invariably affect the opposite side. So what happens after stroke, since it is controlled by extrapyramidal system, the torso is innervated by bilateral connections. So of course, one side is more involved. So when the involvement is more on one side, the other side would pull at a linea alba. So one side becomes short and other side becomes too much lengthened. So they lose the biomechanical efficiency in order to produce a force generation. See, another interesting finding is that since these muscles are attached to fascia, the fascia is this continuum. So they continue extremities. So the control that is developed in the proximal part would influence the distal extremities. This we say the proximal control influence the distal part of an extremities through its facial connections. Next slide, please. Right. So these images are the typical presentations of how the patient with stroke move. You could see a commonest the patterns. Either they move the segment as a whole, which means either they move in a flexion or they move in an extension. They cannot selectively move. In an ideal condition, suppose you need to roll over, you initiate from an upper torso or a lower torso. Whereas these individuals, they kind of crunch, they kind of so that the person uses the rectus abdominis, that is a flexus or a trunk extensors in a mass synergetical way. So this we say atypical movement pattern. Next slide, please.
Dr. Karthik, please keep your mic near to your mouth. Okay, because sometimes your voice is breaking. Sorry, sir. Sorry to interrupting.
Next slide, please. Yeah, exactly. Right. Right. So another aspect is about the upper limb, the synergy pattern. We are concerned about it. So when the postural tone become low, or when the postural muscles are not working, what happens is that the phasic system tries to compensate for the lack of stability, which means the phasic system will play a role of stability. So that's one of the reasons why the patients with stroke use the axioscapular muscular system for an extra stability. So what happens over a period of time is that since they use more axioscapular muscular system for stability, there would be a limited rotation mobility of a torso as well. So you could see in the bottom image, you could see the rotation of a thoracic spine towards more involved side is a kind of okay, but the rotation towards the less involved is restricted. This invariably will limit the disuse of abdominal muscles. So the patient cannot coordinate between upper torso and lower torso while walking. That is conditional for walking. Next slide, please. Right. So basically, the trunk performance, in other words, trunk control, is an ability of trunk muscles to maintain the torso in an alignment up against gravity, adjust weight shifts in relation to the selective trunk movements initiated from upper part of body or lower part of the body, and coordinate with these movements to the functional movements of extremities during dynamic postural perturbations. Next slide, please. Right. So I mentioned about the stability, the postural tone, the tonic muscles should provide a postural tone. So here I'm just talking about the abdominal muscles, particularly the internal obliques and transverse abdominals. So what is dynamic stability? So the dynamic stability of a trunk is nothing but the ability of a torso to maintain certain parts stable but active, so that other part of a torso or an extremity can independently move in a different directions or a plane. This we say coordination. In other words, it is called dissociation, but the dynamic stability is conditional for the torso to move in different directions and plane for functional movement. Next slide, please. All right. So in one of our earlier paper, we did mention about what are the clinical tools available to measure the trunk in a settings. So I will just briefly talk about the three major tools. Next slide, please. The first one is the trunk control test. This is the test that is commonly used in acute care rehabilitation, where you measure 4 items. The ability to roll towards the more affected side and less affected side, followed by the ability to get up from bed and ability to maintain in a seated position. Next slide, please. Right. So what basically you measure in a trunk control test is whether the patient could able to do the movement. Is there any difficulty? In other words, any deviation you see Based on that, you measure the grading. It's a 3-point ordinal scale. The maximum score is 100. You can read further upon referring to the papers. Next slide, please. Right. So this trunk control test is the early predictor of motor recovery of an extremities and functional recovery, measured by FIM and Bothell index. And this is more sensitive in early stage stroke, not in chronic stroke, because of lack of evaluation of quality of movements. And this trunk control is moderately correlated with trunk strength. Next slide, please. The next tool is trunk impairment tool, trunk impairment scale, in other words, developed by Verheiden. This tool is vastly used in research, and in a clinical settings also majority of the therapists do use. So here we do measure 3 subsets, in other words, subscales. The first one is static sitting balance, then dynamic sitting balance, and coordination. In static sitting balance, what the therapist would do is the therapist lift the uninvolved leg over the involved leg, and you look for a postural stability, whether the patient could be able to maintain it. And followed by you ask the patient to lift the sound leg over the involved thigh and look for a postural stability. In dynamic sitting balance, next slide please. In dynamic sitting balance, you measure the selective lateral flexion initiated from an upper trunk or lower trunk. So here you ask the patient to take the elbow to the plinth, or you ask the patient to hike the hip towards the rib cage. So what you measure is whether the patient can selectively control having the other segment dynamically stable. And you look for any compensation. What happens if the patient cannot stabilize one segment? Either they cannot do, or they come up with some kind of a compensation that you can look in extremities, in the lower limb particularly. Next slide, please. In the coordination, similar to dynamic sitting balance, where in the coordination item, you measure the trunk rotation from upper trunk and lower trunk. Here you measure the ability to roll the upper trunk and lower trunk, plus how fast the person can move. Means in 6 seconds, how many times the person can rotate the shoulder forward or move the knee forward. It's basically about the kind of a scooting. So based on the quality of movement, the ability to move, you rate. The maximum score is 23. This tool is widely used in clinical settings. Next slide, please. Right. And the last one is developed by Fujiwara of a same name, but this tool is quite good tool to be used in subacute and chronic stroke, but there are not much research evidence for this. It's a good tool, particularly to use in subacute and chronic tool. So we had done a ROA curve, we did a RAS analysis. It's a good tool to use in the stroke patients. Basically, you measure the trunk verticality, trunk muscular strength clinically, and the ability to regain balance, that we say writing reflex. Next slide, please. In trunk verticality, what we basically do is we nudge the, we tilt the patient after blindfolding the patient. We tilt the patient to one side, and we'll ask the patient to come to a neutral sitting position. And then you measure the position sense error, whether the person has a perception of trunk verticality, and you rate accordingly. Next slide, please. Next. Yeah, next one. So in trunk rotation measures, so the patient is positioned supine, and you will ask the patient to roll over towards less involved side and more involved side, and you look for how well the patient could clear the shoulder blade, which means how contraction you feel in the abdominal muscles. So that's about the trunk rotation strength. So you rate accordingly. Depends on how much of visible contraction you have or how strong the oblique muscular contraction is. Next slide, please. So you can run through a few slides. The next one. Yes. Next one. Yeah. So basically, you look for whether the patient can clear off the scapula, and you look for the strength of contraction in the oblique muscles. That's how you rate the trunk rotation strength. Next slide. Next slide, please. So in the writing reaction, the patient is seated and you nudge the patient and look for whether the strong reflex is elicited or it is poor. So that's how you rate the writing reflex. This will be done on both sides. Next slide, please. Next one. Yeah. Yes. Next slide. Next slide, please. Yeah. Next, we will move on to next one. Right. In abdominal muscle stent, so the patient is seated in a chair, and you basically nudge at the sternum, and you ask the patient to come against your strong resistance, and you check for how strong he could come to a sitting position. Next one, please. Next one. Yes. So, see, I said there are three tools available to measure the trunk control: a trunk control test, trunk impairment scale by Verheiden and Fujiwara. Trunk control test you can use in acute settings. Impairment scale by Fujiwara you can use in subacute and chronic stage. Fujiwara scale, the Verheiden scale, you can very well use in chronic stage. Next comes to trunk muscular stent. Trunk muscles are involved in stroke. It can be measured by isokinetic dynamometer and handheld dynamometer. These tests showed that the trunk muscles are involved bilaterally. The both rotators towards most and least involved side, and bilateral lateral flexors alongside trunk flexors and extensors. Next slide, please. Right. So in clinically, suppose you have the dynamometer available, you can test the trunk muscular stent. We had validated the trunk muscular stent using handheld dynamometer. If it is available, you can use this. It's been validated. Next slide, please. Right. So the trunk control and trunk muscular strength, even in chronic stroke, is positively correlated with the balance capacity, walking, and functional activity as measured using bed balance scale, walking speed, and the FIM. The better trunk control immediately after stroke is the the utmost predictor of the future functional recovery. Next slide, please. So in one of our paper recently got accepted in topics in stroke rehabilitation, we found that there is a strong association between trunk control, core muscular strength, and balance confidence of community dwelling patients with chronic stroke. The interesting finding what we noted with regression analysis that the dynamic sitting balance, particularly the ability to selectively lateral flex, and the trunk rotator strength are the strongest determinants of balance confidence. So this gives you an idea about if at all you emphasize in trunk rehabilitation, you need to emphasize much on the rotator strength as well as the lateral flexor control. Next slide, please. So it's proven that the trunk alignment is not correct. The trunk is poorly aligned in sitting and standing position, and this poor alignment in standing is related to worse trunk performance and balance performance. We measure the lower trunk control and pelvic instability using the outpatient meter. It's called PALM device, and we found that the pelvic tilt, the pelvic obliquity, and the trunk control are positively related, which means the poor the trunk, there is a poor pelvic obliquity, I mean pelvic stability, in other words instability. And this is positively related to the lower limb recovery staging. You can use Fugel-Meyer or you can use Brunstrom's grading, but we found the poor lower trunk control and pelvic obliquity is positively related to lower limb recovery. See, what I'm just conveying is that the proximal trunk control is positively correlated with the lower limb motor recovery. The next slide, please. Right. So this is a palpation meter I said. This is widely used in musculoskeletal condition. But you can use this palpation device to measure the lateral pelvic tilt and anterior pelvic tilt. We observe excessive lateral pelvic towards the most involved side and excessive anterior pelvic tilt because of poor tone in the abdomens. This has been validated. Next slide, please. And we also observe that the pelvic inobliquity and lower trunk control issues are related to poor weight bearing asymmetry between feet. Next slide, please. All right. So as I said, the lower trunk is very much conditional for pelvic stability. The interesting point here is the lower trunk in a seated position, right, where you are mainly concerned about quadratus lumborum, because in a seated position, the hip is being flexed. So the gluteus medius cannot work effectively with the quadratus lumborum because they are in a mechanically disadvantaged situation. Where when you do an anterior posterior balance stability, the abdominals and gluteus maximus should work together. So the pelvis, if you consider, mainly become a part of lower limb in standing because of its biomechanical need. So in standing, the hip muscular control, particularly the proximal musculatures of extensors, abductors, then lower trunk control are positively correlated. And this is further related to weight bearing asymmetry. So I'm just giving an important emphasis here. So don't look into each segment separately, right? So the lower trunk and the pelvic musculature should work hand in hand, should work in a coordinated way, right? This we learned in biomechanics. We say force couple. So that's how the muscle function. The next slide, please. Next slide, please. Yeah, this assumption we confirmed in one of our clinical trials. So what we did is we did a strengthening exercise of lower torso and hip musculatures, that is the lower torso and pelvic stability. We found the exercise regime was beneficial in improving trunk control, then functional measures as well as balance. Right. So next few slides, I run through the technological based assessment of trunk and briefly tell about the intervention. The postural assessment is mainly done by posterography. Right. So the posterography researchers do say that the people after stroke find difficulty in shifting the weight towards the most involved side. They shift the weight towards less involved side. So this inability to shift the weight towards the most involved side is related to a Berg balance scale. Next slide, please. Right. So in standing over a forced platform, majority of the stroke patients do not shift weight towards the involved side. During a functional reach outs, they remain towards the less involved side. So they won't shift the weight towards the involved side much. Next slide, please. Right. So this is an interesting study about the dynamic analysis of a trunk flexion. So we all know the typical posture we observe in stroke patients are that the kyphoscoliotic posture with more weight towards the sound side. So they don't shift the weight towards the involved side. So this is the understanding do we have. Then this is a posterography study where the patient is seated in a stool and the feet are placed over the force plate. The person is asked to flex the torso. So here in the bottom right image, so you have two images. One is about healthy individual doing a trunk flexion. The next one is the person with stroke doing the trunk flexion. In ideal situation, the healthy individuals do a trunk flexion by just rolling over the pelvis anteriorly, which means they coordinate with upper torso and lower torso. Whereas individual with stroke would invariably shift the pelvis posteriorly and they maintain a passive stability and they excessively flex the torso forward. So what happens because of that? The weight shift would be normal. Both individuals would show a typical kind of a forward weight shift. What would not happen is people with a stroke would not shift the weight to the feet, which means the force plates do not pick up the weight bearing because of no, the posteriorly pelvic tilted position. This is conditional for sit to stand, of course. All right. Next slide, please. All right. So since the person passively stabilize the lower trunk with a posterior tilted position, and the lower trunk control is poor, and trunk muscular strength is weak, the study has shown that the trunk strength affects the sit to stand performance. And what happens during sit to stand? The majority of the patients place the torso towards the sound side. So they hardly shift the weights towards the involved side. Next slide, please. And so this is another post-graphic study. So irrespective of placing foot in affected foot, the stroke patients torso remain to be in an affected side. Next slide, please. Right. So in the posterography assessment, I did mention about the lateral weight shift difficulty, and the patient keeps the torso more towards less involved side. So there is an obvious postural deviation during all functional transitions. In the next few slides, I talk about trunk training. So what are the ways we can treat trunk training? So we have two possible options. One is about using the stable support. That's a simple plinth you can use, and the regime is mainly focused on encouraging selective movement of upper torso and lower torso and improve the dynamic stability. Next slide, please. And the next option would be you can use an unstable support medium. Either you can use a Swiss ball, or you can use balance boards, wobble boards. So these are other options. Basically, these exercises are done in supine and seated position. So the assumption is that when you improve trunk control and strength in a seated position, probably it can transfer in other functional positions, sit to stand or walking, something like that. Next slide, please. So we had compared using stable support and unstable support trunk training in early stage stroke. We observe that the people who had used unstable support medium as a treatment regime had shown the better therapeutic benefits on trunk control measures, Brunel balance assessment, as opposed to those who had done a similar kind of training on a plinth. Right. So the possible explanation we could relate is that the postural perturbation of the unstable support medium would demand excessive muscular contraction, in other words, coactivity, and the reactive capacity of a torso. Next slide, please. Right. So another possible option, you can ask the patient to view how he is doing, or how a person with another person who is doing quite good. So the patient can understand how to do this kind of a movement, and the person can reverse this kind of movement in therapy setting. So we had shown that the trunk motor imagery had shown improvement in the related clinical measures. Next slide, please. Right. And similarly, this is my PG thesis. It was a pre-poster trial 10 years back. I mean, long ago, not 10 years. Yeah, 10 years back, this work was completed. So this was in one of the initial paper. So we found the trunk exercises performed on stable support showed improvement in balance and gait performance. Next slide, please. Right. So this one, this is part of my PhD thesis. So this got published in Journal of Stroke and Cerebrovascular Disease. So here we had three groups. One group was practicing regime on a stable support. Other one, similar exercise on an unstable support. The third one was a control group. So we observed that both the regimes, irrespective of stable or unstable support, had shown the beneficial effects on trunk control, balance, physical function measured using a stroke impact scale, as well as the community participation with the community reintegration scale. And this is a large trial, and we had a follow-up until 1 year, nearly 110 patients. We observed that the therapy gain at post-interventional levels been retained at 1 year follow. So interesting finding here is we didn't find any difference between the stable support and unstable support regimes. So here, so you can the conclusion is you can either use a stable support medium or unstable support medium to train the related clinical muscles. Whereas in acute stroke trial, we found much benefits of unstable support medium over stable support medium. Next slide, please. Right. So another one, the recently it's been under revision from APMR journal. So here we measure the trunk muscular strength following core stability exercises, as well as the balance confidence measured using activity specific balance confidence scale. We observe both the trunk regimes, stable support and unstable support regimes, showed a favorable improvement on trunk strength and balance efficacy in ambulatory stroke patients. Yeah, next slide, please. Yeah, so thank you so much for the organizers for giving me this opportunity. Thank you, my colleagues, for your voluntary, the active participation and patient listening. Thank you so much. So in a nutshell, in this presentation, had given an idea about the biomechanical and the neurological connections of trunk, how it is involved, and what are the ways we can measure clinically, and any objective tools and clinical utility tools are available. And lastly, I mentioned about the possible options to treat the torso using stable and unstable support medium. Thank you so much.
Thank you, Dr. Karthik, for enlightening us with this wonderful topic. And because this is sometimes I find it out, the lot of work is doing up, physios are doing on the upper limb and lower limb, and sometimes the trunk got neglected, and the trunk is the main thing which we should focus on. And I'm finding it out, you have done a wonderful work. A lot of research and a lot of publication is there on the trunk. Definitely all the future physio and all the clinician would work on the trunk stabilization and would work for the trunk rehabilitation. Thank you, Dr. Karthik, for guiding us how we should go for the trunk rehabilitation. Thank you.
Thank you so much, sir, for kind words.
Thank you.
Thank you, Dr. Karthik, for such a wonderful presentation. And now we are moving to next session, next lecture, predicting recovery potential in post-stroke patients. And we have with us Dr. Fayaz Khan. He is an associate professor, Department of Physical Therapy, Faculty of Medical Rehabilitation Science, King Abu Laji University, Saudi Arabia. We welcome you, sir. You can proceed with your session now.
Morning. Yeah. So you can see my screen, right?
Yes, sir. Please proceed.
So my voice is clear, right?
Yes.
Okay. So good morning, one and all. I'm Dr. Fayaz Khan, and I'm working with King Abdulaziz University in Saudi Arabia. First of all, I would like to thank the organizers of Neuraxis, Dr. Dharam, Dr. Shaugan, and Dr. Harpreet for giving me an opportunity to share in this platform. So, well, today I'm coming with a topic called the predicting recovery potentials in post-stroke patients. So, well, this might be a new topic for quite few of you. So, I'll be just talking just briefly about the predicting factors of conventional prediction factors. Then I'll just go into the prep formulas. Okay, so I'm just starting with. So just to break the ice, just to break the ice, you can see that stroke, basically the ischemic stroke, which is more vulnerable, and that you have an ischemic penumbra. And if the patient is brought to the emergency department, within the 4 hours of the window period of thrombolysis, and if the patient is being thrombolized, you can save the the ischemic penumbra, and you can salvage a lot of neuron structures. So that is one of the basic predicting factors, that how early you bring the patient to the emergency department, and how the thrombolysis and the clinical management is done. So that, starting with that, then coming into a next paper, which has explained about different predictive factors of post-stroke motor recovery. I'll just briefly go through the different factors. I'm not going into detail into it, well, because this is not the area of concern of today's talk. Well, there are clinical factors, there are socio-demographic factors and genetic factors. Clinical factors, as you know, depending upon the initial injury, how chronic, or how extreme areas which it's been affected, depending upon that, the recovery is predicted. And other comorbid factors like diabetes and depression, the white matter diseases and infection. As you know, if the patient is affected by these factors, the recovery is affected. I mean, the prediction of recovery is slow. Well, coming to the rehab therapies, you know that depending upon the type, timing, and dose and merge therapy, like what type of therapy you use, how well you execute the therapies, like according to the guidelines, the clinical guidelines of stroke rehabilitation, and the timing according to the guideline, like 45 minutes per day, 5 days in a week. So, and the dosage. So depending upon the therapy and the merge therapy, so we are using a facilitated technique along with the normal conventional therapies. Like, for example, you have to be using a non-invasive brain stimulation along with the other physical task-specific therapies. You can get a more recovery, and by that you can predict the recovery, how well it can be done. And these are the clinical factors, and just going briefly into the socio-demographic factors like age. You know that age, the older age group have less recovery compared to the young age group, because neuroplasticity, plastic changes are way less when compared to the young. Gender, females are recognized according to the studies that have less poor recovery, because they are not accessible much to the rehab departments, and they stay at home most of the time. And race, it's not a concern in our country. Well, it may be a concern in the Western countries, where the Caucasians and blacks, the Caucasians Caucasians have a more better recovery than the blacks. And socioeconomic status, as you know, socioeconomic status, if we are affordable to better rehab therapies, we have more recovery concern. That's the socioeconomic status. And there are a lot of genetic factors which I'm not dealing with, like the BDNF and other genetic factors, which may influence. There are a lot of proteins and the molecular level, which may influence the recovery patterns of stroke rehabilitation. So this is a nutshell of the basic clinical factors and social demographic and the genetic factors. So I'm just skipping from here to the next slide, because this is not the main concern of our talk today. Well, in the same paper, they have mentioned about the recent neuromodulatory techniques, like, you know, the non-invasive brain stimulation techniques like the TDCS, the RTMS, and the theta stimulation, and more advanced technologies like the robot-assisted therapies, brain-computer interfaces, and stem cell therapies, all have influenced or facilitated the rehabilitation recovery patterns of post-stroke patients. Anyway, this is also not a concern of our talk. So I was just going briefly into it, because it takes a lot of time to explain all those in a detail. So coming to the main part of a talk, because I want to explain this more in detail. First of all, I'd like to acknowledge Professor Kathy Steiner and her team for doing such a wonderful work on the PrEP formulas. Well, this PrEP, it's called the Predicting Recovery Potential. It was published in the journal Brain in 2012, a long back, might be 8 years back. So they are working in this PrEP formulas for a decade. So in this, what they explains, I will explain with a flow chart with detail about this. It's very simple. So this was the PrEP formula, which was initially formulated. You know, it is a sequence of activities or assessment that we have to do initially within the first 3 to 4 days of acute stroke insult. So, you know, first you have to take the SAFE score. SAFE score means SAFE is shoulder abduction, finger extension. So, you know, the manual muscle testing of grade of 5. So shoulder abduction, finger extension is 5 plus 5 is 10 score. So if we have the patient has a score of 8 and above, you can expect a complete recovery. Okay. And if patient is less than 8, score is less than 8, you have to go for a transcranial magnetic stimulation, single pulse. Not the repeated RTMS, you have to go a single pulse to know the corticospinal excitability, the corticospinal tract integrity. So in there, if the MEP is present, that means you will get an amplitude. If the motor evoked potential is present, you can expect a notable recovery. Okay. And if it's absent, because you can compare with the normal side, if it's absent, you have to go for an MRI. It's called the DTI. So this is TMS. If it's absent, if you'll take the MEP from the any of the upper hand muscles like APB or FTI or any of the muscles from the hand, which is more accessible to the TMS stimulation. And if TMS MEP is absent, they can go for the analysis of the MRI. In that, I think in my previous lectures, I mentioned about DTI, the diffusion tensor imaging. It's called tractography. In that, you can assess the tracts. Tracts means you can see the circle. It's the corticospinal tract at the internal capsule level. So tractography gives a number of tracts, the volume of the tracts. You can compare with the normal side and see the difference between the tracts. There's a difference between, if there is a huge difference between the normal side, the unaffected side, and the affected side, you cannot expect a much better recovery. There's no recovery as such. If the symmetry between, I mean the difference between the both sides, the affected and non-affected side, is less, you can expect a limited recovery. So this is how you predict. I mean, in the according to the SAFE formula. First, you take the SAFE score, the shoulder abduction and finger extension, the manual muscle testing scores. Then, if it's present, it's complete recovery. And if it's absent, go for TMS. If the MEP is present, if there is notable recovery. And if MEP is absent, go for the diffusion tensor imaging by the MRI. Anyway, don't worry about the MRI part, because after this, they have updated with their new formula for PrEP. That's why I'm coming to the next slide, where they have, made it more simple. In a way, we can do the assessment in a more physical manner. Yeah. In 2016, the same team, headed by Professor Kathy Steiner, came with another formula called the PrEP2, predicting recovery potential, the version 2. This is more simple and this is more updated. And you can see. So according to this, the only difference is that they remove the MRI, which is more expensive. Taking MRI is more expensive, and they replace with the NIHS score and validated with, this study. If you go behind the methodology behind the study, it's so difficult to analyze those things. So I'm not going detail into it. Why? Because this was done in 250 patients, and the predictive, the sensitivity and specificity of this formula is more than 75%. So you can expect a 75% accuracy when you're predicting the patient's recovery with this kind of PrEP formulas. So what you have to do is, I don't know how simple I can explain. Like, if you're doing this formula within within the first week, like 3 days, third day, if you assess, you can predict the recovery, how much recovery this patient can expect in 3 months. So they are predicting a recovery for 3 months. So what is the advantage? You will think of why you want to predict recovery. What's the advantage? That I'll come into detail why we are predicting recovery, and why, because you can plan a perfect strategy for treating a patient for stroke. You don't want to waste the time. The first three months, that's the main critical time you get the motor neuroplasticity. So you can save the time during the first 3 months by planning a strategy why you want to do unwanted treatments for when the patient doesn't have much recovery. So that's where I'll coming into that in the coming slides. Well, coming into the PrEP2 formula, the second version, it's more simple. That's doable by a physical therapist, except the TMS part. But if it's available, you can go for it. And here the SAFE score is 5. SAFE score means shoulder abduction and finger extension. The SAFE score is 5. If on the third day, so you are assessing the patient in the hyperacute stage of third day. So it might be in most of the stroke clinics or stroke comprehensive units, you will see the patient within the first 3 days. So in the third day, if you're assessing the SAFE score, it's very simple, right? To assess the shoulder abduction and finger extension, you assess the patient for SAFE score. If it's more than 5, so first category is more than 5, and check the age, because age will be always there in the 5. If the age is below 80 years and below, you can expect an excellent recovery. Well, on the other hand, if the age is above 80 years, that's older age people, you should check for go for the scores of SAFE. And if this SAFE score is more than 8, you can expect an excellent recovery. But if it's less than 8, you can expect a good recovery. Okay, what is excellent, what is good, I'll explain in the coming slides. So go for SAFE score. If patient is below 80 years, If safe score above 4 and above, you can expect excellent recovery. And if patient is above 80 years, go for just check the safe score again. If it's above 8 and above, you can expect excellent recovery. 8 and below 8, you go, the patient can be expected good recovery. Now coming, if the safe score is below 5, that means if they combine the shoulder abduction and finger extension manual muscle testing strength is below 5, go for MEP, that is TMS, the transcranial magnetic stimulation, single pulse. You within 4 to 7 days, because you're doing the safe score on third day, you can do this in 4 to 7 days. So if you're getting in potential MEP, you get an amplitude there. So you have a guidelines for doing the motor potential for the resting motor, RMT, the resting motor threshold. And if you're getting MEP, that is an amplitude of RMT, you can expect good recovery. That age doesn't matter there. And if there is no MEP, like if the corticospinal tract is not integrated, I mean, we don't get MEP when compared to the normal side, we don't get an MEP. Check the NIHS score. NIHS is most of the people therapists you're working with in the stroke units might be knowing what is NIHSS. It's the National Institute of Health Stroke Scale. This is NIHSS. So it's score of 42, and the lower the score, it's better. So coming back, if the NIHS score is less than 7, you can expect a limited recovery. If the NIHS score is more than 7, you can expect a poor recovery. So NIHS score, most of the clinical stroke units, the clinicians usually takes every day. So you have to take the NIHS score of third day. You are assessing the safe score at third day. The NIHS score, which is taken on third day, should be integrated into it. So after the third day, within 4 to 7 days, you take MEP. So in a nutshell, if safe score is more than 5 and the age below 80 years, you can expect excellent recovery. And safe scores more than 5. If the age is below 8, so above 80 years, check the safe scores again. And if it's more than 8, excellent recovery. Less than 8, it's good recovery. Safe score is below 5, go for TMS. If you get an MEP, you have a good recovery. And if MEP, there's no MEP, check the NIHS score. NIHS score less than 7, that's a limited recovery. And if it's more than 7, that means poor recovery. So this is how you predict a recovery pattern of a patient, a motor recovery pattern of patient after stroke immediately in the first week of stroke itself. And you can predict this much recovery can happen in 3 months after stroke. And to remind you, this recovery pattern is prediction of the upper limb recovery. You have a different formula called twist for the lower limb. I'll just go into brief the last section of this talk. So this is about the prep formula. Hope you are you understood about this safe formula. And now coming into what is the importance of doing this prediction of stroke. I have mentioned about complete, notable, limited, and none, 4 categories of recovery in the first slide of the prep one. Anyway, it's same as the excellent, good, limited, and poor recovery. Same. You have 4 categories. In complete recovery, the patient is expected to return to normal or near normal of hand function. I just remind you that again, this is for the upper limb recovery. You can expect a near normal hand function within 12 weeks. That means within 3 months. And what is the goal for your treatment? So if you predict that the patient is getting a complete recovery, so your goal of treatment should be task-specific therapy. You don't want to strengthen that because it be task-specific. More of aerial activity should be enforced. And if in a second case, if a patient is expecting a notable one, the second category, in a 12 weeks, that means the patient has been using the affected hand and arm for most of daily activities, but the normal function, we cannot expect that normal function can be regained to the near normal. It will be near normal. Okay, in that case, the goal of your rehabilitation should be focused on strength, coordination, and fine motor activities of your hand. Okay, and to minimize the compensation of the other hand. So here, you can use the CIMT, the constraint induced movement therapy, those kind of techniques to minimize the compensation of the other hand. So this that's why how you design your strategy for rehabilitation when you have a good recovery predictions. Now coming to the third category, the limited recovery patterns. That means then the patient has a potential to have some movement in their affected hand within 12 weeks, but unlikely that to be used functionally for daily activities. Here, you have to use strengthening activities, more of active range of motion activities, and promote adaptation and incorporation of affected upper limb in daily activities wherever possible. Might be here you can use the bilateral arm training, because you have to use more of for the more functional activities and aerial activities. You can use both hands so that you can synchronize between both hands and do more of aerial activities, because you may not be able to use more of your affected hand. So you can use both the bilateral arm training for this kind of this stage of limited recovery. Now, coming into the fourth one, which you cannot expect in recovery, the patient can expect to have minimal movement in the 3 weeks of in the 3 months of time. So in that case, you cannot expect any recovery. That time, you what you have to do is you have to try for the you have to prevent the secondary complications like the spasticity, the shoulder instability, the HSPs. We have to prevent the whole hemisphere shoulder pain and the subluxation, reducing disability. And also you can also try for the compensatory strategies with the unaffected arm. So so what is the theme here? Like, see, if you're expecting that there is no recovery patterns can happen in 3 months, that if it's very chronic stroke and very severe stroke in the acute stage, you can predict that the patient cannot experience recovery. So why you want to wait unnecessary strategies basing, if the patient's injured, why you want to waste a lot of money and your time spending in different strategies which doesn't work out? So that is the importance of doing and predicting the recovery patterns in stroke patients. So that's about the upper limb recovery. Just briefly into the lower limb recovery, that was published by the same team working on the headed by the Professor Katistina. It's called TIS formula. It's quite simple. Like my colleague Dr. Karthik Babu has explained about the trunk control test. This prediction is done according to the trunk control test scores. Trunk control test scores of above 40. TCT is out of this is the TCT trunk control test points. If it's above 40 at 1 week, you can expect, if the TCT score is above 40, it's it's in hundreds. So if it's above 40 at 1 week of initial acute instead of stroke, you can expect the patient to have independent walking at 6 weeks. If the TCT score is below 40 in the first week, just check the hip extension scores of muscle MMT. And if MMT scores of hip extension is more than 3, you can expect the patient to have independent walking in 12 weeks. But if the hip extension score is less than 3, the patient will be dependent in walking. So this is also having around 70 to 75% sensitivity and specificity, like of accuracy in predicting the independent walking for lower limb. So this is about the upper limb prediction prep formula and lower limb TIS formula. This is about the predicting stroke recovery. So if you want to have further references, you can go to the website called the prestoauckland.ac.nz. So here you can see all these details of the prep formula, how to predict, and there are a lot of case studies on that. You can go into that. You have algorithm for that. So Presto, I have mentioned the Prep 2 is the one which is more updated and it's more easy for, as a physical therapy point of view, is more functional assessment rather than more of technical assessment, except the TMS values. So this is the Presto form, Presto. And you're watching a YouTube, as I know. Might be you can pause for some time after this video and just go through this case study. This is a case study of Mr. C, and you can just see how the predicting. You can just have a homework of how this can be predicted with this algorithm. So hope this was a new topic for you, and I thank all the organizers for and all the participants for a patient listening. Thank you. Thanks a lot.
Thank you, Dr. Fayaz. We appreciate your lecture and knowledge always. And it is not just today, but we understand the importance of your talks and the relevance to all the students as well as researchers. Dr. Fayaz, what is the role of quality of rehabilitation?
You mean quality of rehabilitation or
quality of rehabilitation?
In concern to the
in determining the outcome.
Yeah, that's what I mentioned. In if you can predict, you can design the strategies. You can design strategies. What type of strategies you need, what techniques you need, according to the level of recovery you can expect in 3 months.
Okay.
Does that answer for you?
Yes. Thank you, Dr. Fayaz, for being with us today and sharing this wonderful presentation. Thank you.
Okay, you're welcome.
Thank you, Dr. Fayaz, for such a wonderful presentation. And
Yeah,
with this, we are moving to next lecture. And it's on know how it works before you try to repair. A briefing on motor control. And we have with us Dr. Arunachalam Ramachandran. He is a professor, Madhav University, Rajasthan, India. We welcome you, Dr. Arunachalam, here. You can start with your session now.
Thank you, Dr. Dharam Pandey, sir. The entire team of Neuraxis, which is setting standards for neurorehabilitation in India. And I'm really delighted to be part of this. I also thank all my co-presenters and wish them all success in their professional endeavors. So I think I can share my. Is it visible, sir?
Yes, you can maximize.
So the topic what I have been talking all these days on neurorehabilitation, emphasizing more about throwing light on bringing about how to manage a stroke patient from a theoretical perspective as well as from the practical perspective. So I will always, why this topic was given for this presentation was, if you are trying to repair an object, maybe if you say it is an VCD player, if you want to repair that, what you normally need is the knowledge about how it works, first of all. You may have the most sophisticated gadgets in the world for you to operate on it, but if you don't know how it works, then the intervention what you're going to give for that particular equipment is going to be waste. So what physiotherapists are lacking now is idea about motor control, how movement is being brought about in the human body. If only we know how movements are produced in body, then we'll be able to treat them. Now there is a lot of dispute between this term motor control and motor behavior. So people claim it is not about the control of the nervous system or the environment or the task or whatever it is controlling the movement, but it is the behavior. Like how we behave to our parents, how we behave in the society, how we behave when we are alone. So our behavior is more or less like motor behavior as well. The movement what we produce is also a behavior. So I would like to give you an introduction to motor behavior, and a small definition to that is it includes every kind of movement from involuntary twitches that happens in our body, small twitches, to goal directed activities which are very complex in nature, in every part of the body, starting from the head to the toe, in every physical and social context, from solitary play to group interaction. The group interaction in the sense we interact with the environment, interaction and with the individuals, everything put together. So movement is not a single dimensional thing where we think that there is movement just takes place in terms of magnitude. It is something beyond that. Let me take you through a small historical perspective of what are all the theories which have evolved and what are all the interventions which are available now. If you see, the most evidential theory which came up initially was the reflex theory, which stated by Sir Charles Sherrington, which states that the reflexes are the basics for movement. If I give a sensory input, there will be a motor output. Even still, I see a lot of physiotherapists educating this thing. So sensory input, motor output. See, the problem with here is we need not require sensory input for every motor output. The sensation do not determine, because people who are blind, people who are sensory deprived still move. That is something which is fascinating. So his theory of reflex theory stated that you need a sensory input for movement, and a simple movement takes place with one sensory input. And when it comes to complex movement, it is the chaining of the different reflexes combined together to form a movement. So as theory, he said that when an organism looks into a prey, that is a sensory input for the organism. And as a result of the sensory input, it puts its tongue out and catches its prey. And once the tongue is folded inside, that is a secondary sensory input. It starts chewing. Once it starts chewing, okay, then it starts swallowing. So these are all sequential sensory inputs that are required for a movement to take place. That is how reflex theory is stated. But what problem happened with reflex theory was there were a lot of limitations. It was not able to explain how spontaneous movements were taking place. We do a lot of spontaneous movements, right, which do not have any sensory input. Next very important thing was it was not able to explain how fast and rapid movements which do not give space for the feedback to happen, sensory inputs to happen. They happen very fast, like how we run, how we chew very fast. So all these things happens without any sensory input, how it happens. And same sensory input have resulted in many motor output. For example, if a father slaps a son, that is a sensory input. The son reacts in a different way. If a teacher slaps the son, he reacts in a different way. If a girlfriend slaps a person, he reacts in a different way. The slapping is the same sensory input, but the response from individuals differ. So this was not able to be explained by this reflex theory. And how novel and innovative movement takes place, like how a painter or a drummer or an artist who does some innovative movements, the reflex theory did not do, and invariably it failed. But what reflex theory installed in the intervention point of view is, it said that you can inhibit or you can facilitate a movement by means of sensory inputs. So now, even now, we see people tapping on the muscles of the patient. We give sensory inputs to patients from sensory inputs in the form of traction, approximation, brushing, all these we do. What is our intention? We are giving sensory input to bring about motor output. But my dear friends, this theory is outdated. So invariably, when a theory is outdated, automatically the interventions which are based on these theories are also outdated. So that is why we educate that inhibition and facilitation techniques are not going to work in case of a motor output. Okay, so after this theory came hierarchical theory, which states that like how an institution have a hierarchy. You have your chairman, you have your vice chancellor, registrar, heads. Have a hierarchy in the human body. The brain is your higher center. Then the subcortical structures and the brainstem are the lower centers, and the spinal cord and the peripheral nerves, muscles, and everything combines together to form the lower centers. So this is how it works. Even now, we many people think that our human body is made up of higher centers, middle centers, and lower centers. So this is what hierarchical theory stated, and it was proposed by Hugling Jackson. So all these theories, if you see, my dear friends, are based in 1950s and 60s and 70s. It is so pathetic to see many people trying to stretch muscles, trying to give inputs to patients, trying to modify the motor behavior, even now. So you have to imagine one thing, how actively treating patients, how your thought processing and ideologies are predated and not updated. So I'm not blaming everyone, but I'm just giving an idea about people who still practice on this, and they have to come out of it. That's why that is the concept of this presentation. And the hierarchical theory stated that you have the higher, middle, and lower centers, and it said that very complex and minute movements are taken care by the upper centers, which orders the middle centers, and subsequently the lower centers execute the movement. So in here they said that every activity is, there is a top down flow, or every movement has to be from up to down. There are no movements which are controlled by the periphery to up. Okay, so they said that you have various reflexes in various areas, like your cortical reflex, your brainstem reflex, your spinal reflex. All these reflexes are integrated and the movements are being produced. But unfortunately, what was the problem here was there are some movements which happens from down to top flow. For example, if you want to, if you are putting a hand on fire, immediately you withdraw your hand. So how this takes place? There is no looping of the control to the higher centers, and the time elapsed will harm the organism invariably. So there is no feedback given by the brain, or the organism do not wait for the brain to order the movement. It reflexively withdraws his hand. So there are movements which are also down to top flow. So that is not explained by hierarchical theory, and invariably hierarchical theory also failed. So if you see most of our interventions like Brunstrom's, Bobath, the PNF, and many interventions, Root's approach, all these approaches are based on this reflex hierarchical theory, which states that when the central nervous system is having some problem, the middle centers and the lower centers does the function, and this continues as long as the higher centers take up the function. So this is the assumption which is proved wrong. So whatever intervention which are based on these theories are also outdated. So this information is very loud and clear. So next came a theory called motor programs theory, which stated that there is a rhythmic movement, there is a sequential movement taking place in every organism. This theory was proposed not only by neurologists, but there were also psychologists and the biology professionals. Always, you know, when the biological professional comes into the scene, they always do a lot of research using animals, primates, and vertebrate animals, and they come out with some conclusions. So the same thing happened here, where they did a lot of experiments using locust. You might be knowing locust, which is sweeping North India recently, and also on cats and other primates. They did a lot of studies. They came out with an answer saying that the CNS is not a reactive system. It is not reacting to sensory inputs. It is not based on reflex activity. It is an action system. It has its own rules. It has its own generation capacity. It modifies it. It is very complex, and it is not like what the reflex theory and the hierarchical theory stated. This is something beyond that. So when this was proposed, it was proposed in 1960s to 1970s. So they came up with a lot of experiments. One particular experiment was this particular locust. You can see this locust, it has a rhythmic movement of its wings, which takes place very rhythmically and synchronizedly. So how this movement is possible? It is possible by means of an system called as a central pattern generators. So this theory said that movements like walking, chewing, standing, both dynamic and static activities are all performed by something called as a central pattern generator, which was located in the spinal cord. So they said the spinal cord's contribution for movement is immense. That's why they claim that when there is a spinal cord injury, the patients are rendered disabled for lifelong. Whereas if you see the problems with the cerebral cortex or the central nervous system, sorry, not central nervous system, the brain and cerebrum or the cerebellum, they tend to recover better. But the spinal cord injury patients do not recover because the central pattern generators are affected, and invariably these patients are rendered immobile. So that is what this theory stated. Interestingly, when I went into search of a lot of central pattern generators, I came out to know that people who are training horses, people who are training pet animals for performance oriented sports, do read more into the central pattern generators. They are training horses based upon this motor programs theory. They came out with a significant difference between the animals and human beings, stating that they are quadrupedal animals and we are bipedal animals. So the quadrupedal animals have a better central pattern generators than the human being, and that is why even if they have a spinal cord injury, they recover better than human being. Okay, what they said is the central pattern generators operates at this level, that is in the spinal cervical level for human. So the horses have this area because the forefoot are the one which determines the activity of the hind foot. The velocity of this determines the velocity of this. Like how two-wheel driving car works. So that's how they explain. So even there is a spinal cord injury here, the central pattern generators are intact. So the the animal starts walking. But in case of a human being, our upper limbs are not used for locomotion. We use it only for functional activities like manipulation, exploring the environment, skilled activities. So that's why for injury, we don't recover properly. So that is a major difference between these two organisms. And they also came out with an statement that the program is same when executed with right side as well as left side of the body. For example, this is my signature. My signature, when I do it on my dominant hand and I do it on my non-dominant hand, the structure of the signature remains the same. The content of the signature remains the same. But if you see, it may be slightly different from each other, but the ARUN is same. Okay, so this is what is motor program. Signature is a program. It can be executed by any hand. Based upon which hand is executing, the quality depends, but the content remains the same, because that is what motor programs theory stated. I also did an experiment by asking my son to sign, and invariably I saw the difference was too much for my 10-year-old son, which I clearly understood because his motor system is not completely developed. Sounds good, right? This theory seems to almost touch the core of how movement happens. But there are limitations of this motor programs theory also. This theory has traveled very far away from the central nervous system being a major determinant of movement. The major flaw here was two similar commands, but execution differed in case of a different body posture. Okay, so when a person was standing with a narrow stance, his body posture was differently controlled when he was standing with broader base of support. So based upon the body posture, the central pattern generators differed, but that was not able to be explained by this program. When the environmental constraint differs, for example, walking on a small surface like this and walking on a presumably dangerous surface like this, the body posture differed. The central pattern generators produce different types of movements. Yeah, even though there is no problem here in this walking surface, but still the body posture of the patient differed because he was anticipating some danger or risk. Okay, so this was not able to be explained by motor programs theory. This theory did not also explain how movement differed when there is a fatigue. For example, lifting 10 weights with your biceps. The first movement was performed in a different way compared to the 20th movement. Because the muscle goes for fatigue, all other movements come to contribute for the movement. So this motor theory did not explain how all other musculoskeletal structures, muscles are chained up to produce movements and how fatigue can influence the movements. Finally, the next theory, but what motor control theory, motor programs theory stated? It stated very three clear points. Intervention should be focusing on retraining movements which are not there. Second point is the has to be trained. And third very important rule is not educating a specific muscle is sufficient. You have to re-educate the entire program. Okay, so when they said that there is a central pattern generators which are producing the movements, what is the point in educating an isolated muscle? You have to educate a group of muscles. That's what this theory said. This theory also failed because of various constraints, as I told you. Then came the systems theory, which is almost in existence now because it is a dynamic systems theory which keeps changing its points, its viewpoints and its hypothesis during the due course of time. So it's otherwise also called as dynamic systems theory, which was proposed by Brunstreins. So how environment influences the movement was explained by the dynamic systems theory. So as we told, the flaw as the major flaw in the previous theory. So it also explained how initial position influenced the movement. For example, a person is sitting in a normal seated chair, high seated chair. So if he wants to perform a sit to stand, the the movement pattern and the muscles which are recruited in individual position differs. Here invariably he has to jump, here he has to just go to sit to stand. So the activity, the environment, the task, the individual determines the activity. That is what the dynamic systems theory clearly said to the rehabilitation science. So there are internal and external forces which are going to determine the movement. That is what the dynamic systems theory said. So when I say internal movements, the force which are created by the muscles are the internal forces. The external forces may be the load of the limb, the load of the object which you are lifting, or even the gravity may be the external forces. So this theory clearly said that the interaction between the internal forces and external forces is the one which determines the movement. Okay, so motor starting from the reflex activity, now it is going more into complex activities. Okay, so the top-down determinants of movement like proved this. There is nothing called as top-down flow or the CNS or the motor programs which are existing. It is all rubbish. They said that there is a bottom-to-up factors like the structures of the body, the environment, and the nature of the task on hand are the one which determines the movement. So if I want to explain to you in a different way, I can tell you that compare two activity. A person who wants to take a bottle of water from a desk, he take the tumbler of water and drinks it very simply. Okay, in case if this water bottle is kept on the loft, what happens? His movement entirely differs. He has to reach out and he has to pluck the bottle invariably from the top and he has to drink the water. In case if the ambience where he is sitting is on the floor, he has to get up from the floor. If he's sitting on the chair, he has to stand from the chair. So the movement strategy differs based upon the environment, the object on hand, and all other constraints. So this is what it is about the central nervous system choosing movements, but the movement which is chosen is based upon the environment he is put into. Okay, and they said that all the systems in our body, starting from the musculoskeletal system, the nervous system, respiratory system, all these systems are focusing on one particular task, like how a honeybee works. There are a lot of honeybees. The only aim of these honeybee is to gather honey. Likewise, we have a lot of muscles in the body. The muscles all along with the nerves, the bones, ligaments, and everything combines together to work to accomplish a task. The ultimate goal for organism is to complete the task. If everything is intact and the task is not completed, then the organism invariably fails. So that is what this theory stated. So this is what I told you. Based upon where the object is there in the environment, your reaching pattern differs. A small example for the reaching pattern. They also said that there is a synergy. When I always say synergy, people always think that it's abnormal. Synergy is not abnormal. Synergy means a combined activity, contribution from all the aspects for accomplishment of one particular aim. We normally say for the successful completion of neuraxis, there should be a synergistic action from all the participants and the organizers. So that is called as synergy. So muscles, nerves, body posture, everything is into one particular synergy. And who determines the synergy? The task and the environment determines the synergy. So this theory stated that movement is produced by the interaction between task, individual, and the environment. Okay. They also said something called as variability in movement. Why variability in movement is required? You should know how to perform a single activity in a different way that adds variety to yourself. If one variety fails, you can one mode of action fails, you can have plan B and plan C. All other theories saw this particular variability as an error. When a person did movement in an abnormal manner, that was an error. It was an abnormal movement pattern. And they said that this movement can be refined by means of training the normal movement pattern. So this theory said that there is nothing called as movement pattern, because you should have variety of movement. Only when there is a variety of movement, you can see this is called as the attractor state. So more variety of movement, the ball goes more deep into the surface. You become more stable. Okay, so variety of movement is a must for every individual. So this is what this theory stated. What is the limitation? Moved away from the nervous system again. They did not give much emphasis to the nervous system for the movements to happen. They emphasized more of non-neural structures for the movements to happen. So though you see this as a limitation, but in practical, when you're working with patients, this may not be a limitation, because you see the clinical implications. You have a lot of clinical implications. You are giving more biomechanical considerations to every movement. Many systems combines to form a movement is a very important statement, because all this time the neurodevelopmental theories did not include the participation of the musculoskeletal structures and the respiratory structures. Just imagine a COVID patient. His motor system is intact, his nervous system, his all other musculoskeletal systems are intact, but oxygenation is not possible because of poor respiratory system. He's not able to perform a good oxygenation to his body. So invariably his movements completely fail. So how often we train stroke patients for respiratory functions? So these are all the questions which were raised by the systems, dynamic systems theory, which moved far away from the nervous system into other systems in explaining how movements takes place. Okay, we also came to know that we have to treat patients in different environment. Just making a patient to do a sit to stand in a chair is not sufficient. Making him to do sit to stand from a toilet commode, from a park bench, or from a bar bench, all these things are essential. And environmentally, if you train the patient to be socially fit, then only your rehabilitation is complete. So that is what this theory said. And very importantly, you should train variability. One particular task, if they have only one variability, the system is unstable. You have to teach the patient how to do the same task in a variety of manner. Okay, and the next theory was ecological theory. For this, I always tell my students about how in the movies, if you see at the time of a fight, just few seconds before the fight, the hero will visualize what are all the objects on the environment, what are all the objects he can utilize to fight the enemy. So, and then once the fight starts, he'll utilize all the gadgets and hit the enemy, and he'll come out successful. You can see these things in many Hollywood movies also. So this theory stated that whatever objects which are there in the environment determines the movement. For example, if you want to kill a snake which is there, which is trying to bite you, if you have a stick, you will use the stick and kill. If you don't have anything, you will put your leg onto the snake and you will kill it. So what are all the objects available on the environment determines the movement. And also the objects which are moving very faster are treated differently compared to slower. Kid, it will not try to grab objects moving very fast. It will grab only objects which are moving very slow. So same thing with the adults also. When a ball is traveling very fast, we use a different strategy to catch the ball. When a ball is traveling very slow, we have a different strategy to catch the ball. So this theory also emphasized that the ecology, that is the environment, determines the movement more compared to the other theories. And the last theory which I am going to present today, because there are a lot of theories, I cannot put all these theories into this program. The task-oriented theory stated that every task has to be broken down into its components. A lot of components combines together to form one particular task. You can train individual components separately and incorporate that into a functional task. So likewise, my dear friends, why I am emphasizing on motor control is every single neurological approach which are used in nowadays clinical practice do have a theoretical background. if an approach do not have a theoretical background, like you say cupping therapy, which do not have a physiological background, then those theories are not at all eligible to be discussed or disputed. Theories which approaches which have theoretical approach has to be disputed, has to be discussed. If in case the theories are outdated, those interventions also are outdated. So simply because we have read all these things, we cannot use them on patients. So with this, I would like to tell you that there are a lot of books on motor control and motor behavioral theories, which have completely shifted our approach on normal posture, normal movement theories into ideal posture theories. So physiotherapists update their knowledge on how movements takes place, because we are termed as movement scientists. When we claim we are movement scientists, we should know everything about movement. So with this, I conclude my presentation. I'm open for questions. I wish everyone a very good and very happy physiotherapy day coming up day after tomorrow. And I thank the Neuraxis team for the opportunity. Thank you.
Thank you, Dr. Arunachalam. And I think you have raised very important points, not only about motor control, but about professional development. And I think rightly accepted, neuro rehabilitation has a long way to go still in improvement. Uh, and how do we, there was a question on how do we apply an approach or a theory in clinic?
By mastering the theory, we have to comprehend first of all what the theory says, what are the assumptions about the movement as such the theory says. So we have to put it into clinical practice. For simple example, when I say that the starting position of a human system is very essential for the movement determination, I should try to put my patient in different positions and ask him to do a particular activity, thereby observing his motor behavior. If there is any variations in motor behavior, I will accept it. So it is not necessary that all the assumptions which are given in the theories should be correct. A clinician should put all these things into effect, and he has to come out with clinical research determining whether it is true or not.
Right. So the actual question was like how you interpret a theory or its assumptions. What aspect of it do you give more importance? Can be different for different clinicians, and
Yes.
therefore the application of the same theory or the same approach may be very different, or we can all be same and stereotype.
Yeah, that is true. I can comprehend your question now. That's a good question. There are no theories which are stated as the correct theory as of now. There are no theories which are there are theories which are completely disproved, but there are theories which are not completely accepted as well. There are a lot of flaws in each and every theories. We cannot come out and say that this theory is an optimal theory for every physiotherapist to follow. At the same time, we can say these theories are completely outdated, and following them is not going to benefit the society.
Right. Right. So I think there is a message that people can take away from this lecture, and a lot to learn from you, Dr. Arunachalam. And thank you for being with us and sharing your thoughts. Thank you so much.
Thank you.
Thank you so much, sir, for such a wonderful and nice presentation. And hopefully the audience and participants will learn a lot from this presentation. It was such a wonderful. And with this, we are moving towards the closing of scientific session day 2. And Dr. Sagun Agrawal uh, and Dr. Harpreet, please join me to thanks all the participants, including faculty and our organizing committee members for participation in Neuraxis 2020. And with this, we are moving ahead with the next validation ceremony. And I would like to invite Dr. Sagun to
Thank you, Ram sir.
So here we go with the valedictory ceremony. And Dr. Sagun, I would like to invite you to please welcome our guest today for valedictory ceremony.
Good afternoon, everybody. Thank you, everyone, for this wonderful support. Uh, Whenever we come to the valedictory function, it's not easy to say we have come to the valedictory ceremony. It has taken up around 1 month. From last 1 month, all the committee members has worked hard, and that's the result of all the teamwork that today we are onto the valedictory ceremony is there. So first, I would like to thank all the committee members. Just because of your teamwork, it has been a successful 6th Neuraccess 2020. Now, for our today's ceremony, we are having guests with us, Shrimati Anshu Bansal ma'am. Ma'am is Joint Secretary in IMR Group of Institution. We welcome you, ma'am.
Thank you.
We are having with us Dr. V. Raj Lakshmi. Dr. Raj Lakshmi is Vice Principal in Dr. MGR Education and Research Institute, Chennai. We welcome you, Dr. Raj Lakshmi, ma'am.
Thank you, sir.
Thank you, ma'am. We are having with us the Dr. Rajiv Agrawal, sir. Dr. Rajiv Agrawal, sir, is Head of the Department in Department of Neurosciences, Department of Physiotherapy, AIMS. We welcome you, Rajiv, sir. Rajiv sir, we welcome you, Rajiv sir.
Shagun, can you hear me?
Yes, sir.
Thank you, thank you.
Thank you, sir. Thank you, sir. Thank you. So I won't waste our time. First, I would request Mrs. Anshu Bansal ma'am to come forward on the virtual team and announce the name of the poster competition and enlighten us with few words. Thank you, ma'am.
Thank you, Shagun, sir. First of all, I would like to congratulate all the organizers and committee members, faculty members, and delegates for participating and for the successful Neuraccess 2020. The winners of the event of this e-poster is, first position is backed by Riya Pandey. Second position by Rishita Dubey. And third is Zaveri Fatima. Congratulations to all for this successful winning and participating in this event. This Neuraccess 2020 is being organized and hosted by IMR every year. This year, when the entire world is fighting with this COVID pandemic, IMR has still taken this step, and they are continuing with this Neuraccess and move forward for work as usual. We still believe that very shortly we shall all together get relief from this pandemic, and life will be on track as usual. We are running this BPT from 2000 onwards, and indeed feel proud when we say that IMR is the first institute in the entire UP to start MPT program. A renowned and trustworthy name, IMR in physiotherapy, and we are running biotechnology, microbiology at UG PG level. I wish you all for the success of this event, and next year we shall meet physically and rather virtually, and pray for the happy and peaceful life for everyone. Take care and be healthy. Thank you very much for inviting me and making me the part of this event. Thank you so much.
Thank you, ma'am. Thank you so much for enlightening us with your powerful words. Definitely next year we would be coming offline, and definitely it would be a mega event. Thank you for the support. And IMER is always a pioneer into the new access. Thank you, ma'am. Now I would like to invite Dr. V. Rajlakshmi, ma'am.
Yes, sir.
Thank you, ma'am, for giving your time. And I would request you to kindly declare the result of quiz competition and say a few words to our audience.
Good morning, sir. I'm very much excited to announce the prize winners of the quiz competition. The first prize goes to SRM College of Physiotherapy, Roshni L, Ragini Kumari, Annie Blessy. The second prize goes to Saket College of Physiotherapy, Panchakul, Surneet Kaur, Chandini Dul, and Anshika Bharadwaj. The third prize goes to National Institute of Locomotor Disabilities, Kolkata, Sanlak Kundu, Ritu Batwari, and Nirmalendu Bech. So I must really appreciate all the prize winners and all the participants for their efforts taken during the pandemic situation. Even this pandemic situation, when everything goes online, so students have taken initiative in participating for online competitions without wasting their times in playing PUBG and all those things. And I would like to remember a quote by Walt Disney: all our dreams can come true if we have courage to pursue it. No matter where we go or what we do, there are challenges ahead in our life. So, what I'm asking from each and every one of the student is to meet those challenges straight on with your head held high and heart wide open. So, you must try to excel in everything you do, whether it is big or small. Your individual success will benefit the society as a whole, and you are in a position to give rather than to take. Imagine if every individual lived up to his or her own potential. Think how amazing the world would be. So, my challenge to each and every one of the students in this pandemic situation is that you have to do everything, whatever you can, to reach to your full potential. The future is in your hands. So build up the future. Thank you. I thank Dr. Shagun Agarwal sir for giving me an opportunity to be in this platform announcing the prize winners. I also appreciate all the organizers of this New Access for taking much pain, because working online is too difficult and too strenuous too. So I thank and appreciate all the organizing committee members of this New Access 2020. Thank you.
Thank you, ma'am. Thank you for the golden words. Definitely, we would work hard, and our physiotherapy, all students and professionals will work together to uplift this profession. And definitely, we are the movement scientists, and we will work together for upliftment of profession. Thank you, Dr. Rajlakshmi, for sparing your valuable time. Thank you, ma'am.
Thank you.
Now, I would request to invite our esteemed guest, Dr. Rajiv Agrawal, sir, for announcing the prizes for the paper presentation, both in the junior category and in the senior category. Dr. Rajiv Agrawal, sir.
Okay, thank you. Am I audible?
Yes, sir. Yes, sir.
Oh, thank you. So first of all, I would like to thank the organizing committee, Neuraxis 2020. It's the sixth consecutive year that Neuraxis is being organized by this team. And in that specifically Shagun, Dharam, and Harpreet, this trio is really working hard along with the whole team. And I must also appreciate the IMR Institute, who is always helping people to organize this Neuraxis every year. Of course, I had always been associated with this Neuraxis every year, and thanks again for inviting me in this validation program. First, I would like to announce the results of the junior papers. The third prize in the junior paper categories goes to Tania Goel. Second prize goes to Shehzad Al Jaharani. And the first is Apurva Srivastava. congratulations to all the winners of the awards of the junior paper. In senior paper category, the third prize goes to Sanidhya. Second prize goes to Rajni, and the first prize goes to Rahimun. So congratulations again to all the presenters of the scientific paper. It takes a lot of toll to make one research study, and thanks to all the participants who presented their researches in the Neuraxis. Successful conference only goes with the good scientific papers, good scientific discussions. So thank you to all the participants. Apart from that, I would like to highlight certain things that we all are in a very noble profession, physiotherapy, health profession. We all know, like Shagun told, we are all movement scientists, and people need us. And when they need us, we must fulfill their expectations. What they expect from us, what services we are delivering, what is our product that we are delivering to them. So the quality of the product and services will define our future. So if we will improve our product and services, definitely our profession will grow. And improving the services and product, it's a collective effort, not of only of the same profession, but it's an interdisciplinary profession. Like if we involve more and more professionals, more and more industries with us, definitely we will come out with a better products and the services. So overall, my simple message is try to improve the products that we are delivering and the services. Products means whatever the healthcare services we are providing to our patients or clients. With that, we can add value of the money that they are spending for their treatment. So when a person gets a value for their money, definitely the profession goes up. So overall, I congratulate all the participants, all the organizers, and the physiotherapy community for getting together and making it a very successful conference, Neuraxis. Thank you to one and all. Thank you very much.
Thank you, sir. Thank you so much. Rajesh sir is the integral part of Neuraxis team from the Neuraxis 1. I still remember sir is our organizing chairperson, and under the guidance of Rajiv sir, we are trying to give some work. Okay. Thank you, Rajiv sir, for all these things, for your always your support. Thanks for your wonderful support, sir. Now I would request Dr. Harpreet and Dr. Dham to come together and conclude the session.
Yes, sir. And we are very thankful to all the participants, listeners, our guests, our faculty to be the part of Neuraxis 2020. And we have successfully completed these 2 days colloquium, Neuraxis 2020. And thanks to all participants. And Dr. Sagun, you can just give the vote of thanks to everyone.
I would like to invite Dr. Harpreet, sir. Please come and conclude the session, sir. Harpreet, sir. Okay, with this note, I would like to thank all our resource persons, our chief of guest, and our guest of honors, and our delegates. Really, in the last 2 days, there was a quality of papers was there, and all the teams has participated in the quiz. They have participated with the very quite enthusiasm, and a lot of bachelor's students presented their poster. Thank you for all your response, and thank you for all the 1,500 delegates, and definitely with the technology, all the attendees have marked their attendance to the Google form, and definitely they would be getting their certificate very soon. The students who have given their attendance, that students only will get their e-certificate. With this note, thank you everybody. Thanks a lot for making this conference successful. Thank you.
Thank you so much. Thank you, sir. Thank you, everyone. And with this note, we are closing.
Thank you, everyone.
Thank you, sir.